We are reviewing Modern Management of Mantle Cell Lymphoma by Tobias Tix, Manish Kumar, Toby Eyre, and Martin Drayling, published in the American Society of Clinical Oncology educational book. For years, autologous stem cell transplant was considered essential first-line therapy for younger, fit patients. The evidence now suggests many may not need a transplant at all.
The evidence also shows a stark contrast between two BTK inhibitor trials in older patients, alongside a growing set of cellular and bispecific options for disease that continues to relapse.
This is a narrative synthesis rather than a systematic review or meta-analysis. It covers modern management across the full disease course without reporting specific search dates or databases.
That means frontline therapy for younger, fit patients, and for older or transplant-ineligible patients, treatment of biologically high-risk disease, and the growing menu of options for relapsed or refractory disease. It doesn't report specific search dates or databases, since it's a narrative rather than systematic review.
This program summarizes attributed medical reporting for educational and informational purposes. It does not provide medical advice. Mantle cell lymphoma spans a wide biological range, from indolent forms to aggressive disease with early treatment failure. The review describes the MCL International Prognostic Index, or MIPI, based on age, performance status, LDH, and leukocyte count, which sorts patients into low, intermediate, and high-risk survival groups.
Layering in tumor biology sharpens that picture further. The MIPIC adds the Chi-67 proliferation index, and blastoid or pleomorphic morphology, and TP53 alterations mark out patients with particularly poor outcomes. European guidelines now recommend checking Chi-67 and TP53 status at both diagnosis and relapse.
And increasingly, minimal residual disease testing, now feasible by next-generation sequencing at a sensitivity of 1 in 100,000, is shaping treatment decisions in real time, not just at diagnosis. Not everyone with MCL needs immediate systemic therapy. A minority have an indolent, leukemic, non-nodal presentation, and the review describes a shift toward active surveillance in selected asymptomatic patients with this pattern.
True early-stage, localized disease is uncommon, and the review stresses that thorough staging, PET-CT, bone marrow exam, and GI endoscopy matters, because subclinical bone marrow or GI involvement shows up often even when disease looks localized on the surface.
For carefully selected stage 1 patients with favorable biology, observation, or involved site radiotherapy can be reasonable options, though the review notes the evidence base here is limited. The pivotal trial here is Triangle, a phase 3 study of 870 patients under 65, comparing standard induction chemoimmunotherapy plus autologous stem cell transplant against that same regimen with ibrutinib added against an ibrutinib-containing regimen without transplant at all.
Adding ibrutinib made a real difference. 3-year failure-free survival rose from roughly 75% with standard therapy to 86% in the ibrutinib-containing arms, a hazard ratio of 0.64. Overall survival exceeded 90% at 3 years in those arms too.
That established ibrutinib as a core part of modern first-line therapy for younger, fit patients, but it also set up the next question the review tackles with a BTK inhibitor on board: is transplant still necessary? Maintenance therapy is where a lot of that durability comes from. In a large randomized trial, 3 years of Rituximab maintenance after transplant significantly improved 4-year progression-free survival, 83% versus 64% with observation alone, and overall survival, 89 versus 80%.
Within Triangle itself, adding rituximab maintenance on top of ibrutinib further improved progression-free survival, especially in patients who'd had a transplant. The trade-off: higher rates of severe infections across all arms and more hematologic toxicity specifically in the transplant arm.
So maintenance is clearly valuable, but the review is careful to frame it as something requiring ongoing reassessment, not a fixed, one-size-fits-all duration. A real-world analysis of 4,216 newly diagnosed patients found that, among those eligible for transplant, ASCT itself wasn't associated with a significant improvement in time to next treatment or overall survival. What was associated with better outcomes: rituximab maintenance.
And Triangle itself backs that up directly. The ibrutinib-containing arm without transplant wasn't inferior to the arm with transplant, 85% versus 86% 3-year failure-free survival. The extra benefit from ASCT looked modest, and was offset by added toxicity during maintenance.
One caveat worth keeping: post-hoc analyses suggested ASCT might still help a specific subset, patients with blastoid morphology, very high Ki-67 or p53 overexpression. So this isn't a blanket skip transplant conclusion, it's a more selective one. TP53 alterations predict early treatment failure and short survival even with intensive chemoimmunotherapy and transplant. So this is where targeted, chemotherapy-free combinations are being tested most aggressively.
One example, a phase 2 study of zanubrutinib, obinutuzumab, and venetoclax, the Beau-Ven regimen, in previously untreated TP53 mutated MCL. It reported a 96% overall response rate, 24 of 25 patients, with an 88% complete response rate.
A similar triplet, acalabrutinib, venetoclax, and rituximab, called AVR, showed an 88% response rate and 65% complete response rate in TP53 mutated patients in the ongoing TR-VRSE trial. Encouraging, but the review flags that longer follow-up is still needed for both. Given how poorly high-risk MCL does with conventional treatment, researchers are testing whether moving cellular immunotherapy earlier into the frontline setting can change that trajectory.
In the phase 1-2 GLOVE trial, combining the bispecific antibody glofitamab with venetoclax and lenalidomide in untreated high-risk MCL produced a 100% complete response rate, with high rates of undetectable MRD, though follow-up is still short.
The Window 3 trial went further, following acalabrutinib rituximab induction with brexucabtagene autoleucel, a CD19 CAR-T product in untreated high-risk patients, a 95% complete response rate by day 30 and 94% one-year progression-free survival.
That came with frequent CAR-T-related toxicity, including high rates of cytokine release syndrome and neurotoxicity. A follow-up trial, Carmen, is now comparing an early CAR-T strategy against standard chemoimmunotherapy plus ibrutinib and transplant.
This is Conference Hype. Stay with us, coverage continues. For patients 65 and older or those with significant comorbidities, several chemoimmunotherapy backbones remain in use. R-CHOP was long a default, median failure-free survival of 2.4 years, median overall survival 6.4 years in the European MCL elderly trial, but its use has declined.
Bendamustine rituximab, or BR, took over as preferred, after trials showed numerically better progression-free survival and a more favorable toxicity profile, less cardiac toxicity, fewer serious adverse events, less neuropathy. Real-world US data confirm it's now the most commonly used regimen.
Two other options: VRCAP beat R-CHOP on both PFS and overall survival, 24.7 versus 14.4 months, and 90.7 versus 55.7 months, but with more hematologic and GI toxicity. RBAC gets high response rates without needing maintenance, but its hematologic toxicity has limited adoption outside select, very fit high-risk patients. After R-CHOP, rituximab maintenance clearly helps, median progression-free survival of 5.4 years versus 1.9 years with interferon maintenance, and overall survival of 9.8 versus 7.1 years in the European MCL elderly trial.
But after BR specifically, the picture is murkier. A randomized trial of 120 patients, STY-L-NHL 7-2008, also called Maintain, found no significant PFS or OS benefit from rituximab maintenance there, possibly because bendamustine's lymphodepleting effect blunts rituximab's efficacy and raises infection risk.
Even so, several large observational studies have reported better survival with BR followed by maintenance versus BR alone, and it's been used as the control arm in multiple phase 3 trials. On balance, the review still recommends 2 years of rituximab maintenance after first-line induction in older patients. This is one of the most instructive contrasts in the whole review. 2 phase 3 trials tested adding a continuous BTK inhibitor to BR plus maintenance in older patients. SHINE tested ibrutinib, ECHO tested acalabrutinib.
In SHINE, ibrutinib BR improved median progression-free survival, 81 months versus 53 months, p equals 0.01. But there was no overall survival benefit, and that was driven by more treatment-related deaths in the ibrutinib arm, 11% versus 6%, plus more atrial fibrillation, hypertension, and major bleeding. The FDA didn't grant full approval, and it's not recommended as first-line therapy in older patients.
ECHO told a different story. Acalabrutinib BR improved PFS 66 versus 50 months, hazard ratio 0.73, and the FDA and EMA did approve it. It's still more toxic than BR alone with more diarrhea, atrial fibrillation, and bleeding, but overall survival wasn't significantly different between arms and treatment-related deaths were balanced. So if acalabrutinib BR works well upfront, is it actually better than just giving BR first and saving the BTK inhibitor for relapse? A retrospective analysis from a U.S. consortium found that sequential BR then C BTKI produced a median event-free survival of 68.1 months.
That's strikingly close to the 66.4-month median PFS with upfront acalabrutinib BR in ECHO. So which approach is actually better?
The review doesn't declare a winner. It notes upfront combination shows higher complete response rates and particular benefit in high-risk subgroups, blastoid or pleomorphic histology, high Ki-67, high-risk MIPI, but says the choice ultimately requires weighing individual disease risk against competing toxicity risks like infection, bleeding, and cardiovascular events.
This is Conference Hype. Stay with us, coverage continues.
For older or frail patients who want to avoid chemotherapy altogether, ibrutinib plus rituximab has been studied in lower-risk patients, those without blastoid morphology or very high Ki-67. It produced an 84% overall response rate, 71% complete response rate, with 3-year PFS and OS estimates of 87 and 94%.
But tolerability was a real issue. 42% of patients discontinued ibrutinib because of adverse events, including 22% with grade 3 or higher atrial fibrillation.
A Phase 3 Enrich trial then tested this doublet against standard chemoimmunotherapy in patients 60 and older. It beat R-CHOP clearly, 5-year PFS of 52.4 versus 19.2%, but was roughly comparable to BR, 50.8 versus 47.4%, and it didn't meaningfully help patients with TP53 mutations or blastoid disease. Second-generation BTK inhibitors seem to solve some of that tolerability problem. In the ALTAMIRA study, which used an MRD-guided, time-limited approach with acalabrutinib and rituximab, 2-year progression-free survival and overall survival were 75 and 84% overall.
But that overall number hides a big split by risk group, 91% 2-year PFS in low-risk patients, versus just 32% in high-risk disease. That's a real reminder that biological risk stratification still matters even with a well-tolerated regimen.
A separate Phase 2 trial at MD Anderson reported even stronger numbers in older patients, 92% 2-year PFS, 96% OS, with only one patient, 2%, developing even grade 2 atrial fibrillation. A UK trial, Carmel, is now testing this combination specifically in elderly or frail patients. Pulling several trials together, OASIS, AVR and TR of VRSE, BO-VEN, and MAVO, these triplet regimens combining a BTK inhibitor, a BCL2 inhibitor, and an anti-CD20 antibody are, as a class, among the most active first-line options studied in MCL.
PET-based response rates run roughly 90 to 100%, with complete response rates around 80 to 90%, and high rates of undetectable MRD. 2-year progression-free survival lands around 72 to 82%, even in TP53 mutated disease, and 86 to 88% in unselected patients.
That's genuinely impressive, but the review is clear this isn't yet a standard of care. Longer follow-up and head-to-head Phase 3 trials against standard BTK inhibitor plus chemoimmunotherapy are still needed. And the added toxicity of a triplet may not suit frail patients where a doublet could be enough.
This is Conference Hype. Stay with us, coverage continues.
For relapsed disease, a covalent BTK inhibitor on its own, ibrutinib, acalabrutinib, or zanubrutinib, remains the standard second-line approach after first-line chemoimmunotherapy. There's no head-to-head data comparing the three directly, and outcomes are better when used at first relapse rather than saved for later lines.
The most successful combination partner has been a BCL2 inhibitor. In the SYMPATICO trial, venetoclax plus ibrutinib showed superior efficacy and progression-free survival compared with ibrutinib alone, the trade-off being more cytopenias and GI toxicity. It's not yet FDA or EMA approved.
Early data on a newer pairing, zanubrutinib with the next-generation BCL2 inhibitor Sonrotoclax, reported a 79% response rate in 47 patients, with no tumor lysis syndrome or notable cardiac toxicity. That combination is now being tested against zanubrutinib alone in a randomized phase 3 trial. Once a covalent BTK inhibitor stops working, Pirtobrutinib, a reversible non-covalent BTK inhibitor approved based on the Bruin trial, is an option. In 152 heavily pretreated patients, most who'd stopped a prior BTK inhibitor for progression, it produced roughly a 50% overall response rate and 15% complete response rate.
Median progression-free survival was short, 5.6 months, but patients who responded and remained BTK inhibitor sensitive stayed in response, a median of 21.6 months. And response rates varied sharply depending on why patients had stopped their prior drug.
If they'd stopped because of intolerance, the response rate to Pirtobrutinib was 90.5%. If they'd stopped because the disease progressed, it dropped to 43%. Lower Ki-67, meaning less proliferative disease, also predicted a better response. On the plus side, Pirtobrutinib was very well tolerated, with low rates of dose reduction or discontinuation.
The review also flags Sonrotoclax, a newer BCL2 inhibitor, as monotherapy in heavily pretreated patients, a 53.4% response rate, but a shorter, 6.5-month median PFS, and notes early BTK degrader data are still awaited.
Two CD19-directed CAR-T products, brexucabtagene autoleucel and lisacabtagene autoleucel, are FDA-approved for relapsed MCL after a BTK inhibitor. Both produce high complete response rates and durable remissions in many patients, but come with real risks: cytokine release syndrome, neurotoxicity, and infection-related morbidity and mortality. The review notes long-term follow-up hasn't clearly shown these are curative yet.
biggest open question sits in the relapse setting, with Bruin MCL 321, Celestial RMCL, and GLOBRYTE all still enrolling or awaiting results. We don't yet know the optimal sequence of BTK inhibitors, BCL2 inhibitors, CAR-T, and bispecific antibodies for patients whose disease returns after a first-line covalent BTK inhibitor.